everyone, and a very warm welcome to all present here. Respected principal, teachers, our lovely alumni and students. It is with great pleasure that I welcome you all to the 12th edition of KAA Talk. The Alumni Association for K.M. Patel Institute of Physiotherapy was formed in April 2005 and it's functional since then. Over the years, this platform has evolved into a space of insightful discussion, knowledge sharing, and thought-provoking conversations, and today is no exception. This meet also enables the alumni to notice the changes and developments happened in the college campus then and now feel nostalgic about it. Before starting this event, let's remember Almighty and take blessings. I request everyone to please stand on their places for the prayer. It is my privilege to extend a warm welcome to our esteemed principal, Dr. R. Hariyara Prakash sir, whose guidance and leadership have been instrumental in shaping the success of KAA Talk. I welcome you, sir, to deliver the opening remarks and set the tone for this inspiring session.
Good afternoon to all of you. Full house. I'm happy to see the whole auditorium almost getting filled up. And it's an important occasion for KMPAB because wherever we try and connect with alumni, we take pride in that. And it's a happy moment again for us. And we have with us Dr. Ruchi Shah, who belongs to our institution and passed out in 2009. So seeing her, we felt very happy, very emotional. She went around the campus. That's how the linkage gets strengthened as the institution welcomes the alumni and alumni comes back to the alma mater. So as Disha said, this is one of our biggest initiative, I should say, KMPAB, where we wanted to strengthen the knots of alumni, which we found it as one of the weakest links. We are doing well in academics, clinical, even community outreach programs. Overall, we are doing good as compared to many of the institutions within the state and outside the state. As we observed, we felt the linkage between the passed out alumnus and the institution is a little bit weaker. So to strengthen that, we initiated this platform, which is KAA Talk, KMPAB Alumni Association Talk. And as we stepped into this 25th year, Silver Jubilee year, we just completed that and we are in the 26th year. We made frequent KAA Talk last year. We had multiple alumni visiting our campus. We had one mega alumni meet also where students who are living in abroad came to our campus. We had very good interactive sessions and we could able to rejuvenate all those lost connections and we are now growing a bit stronger. I'm sure in the next coming couple of years, we will have good number of alumni who are going to be with us for the growth of the institution. And one such alumni is Ruchi Shah. She has made herself prominent in the United States by taking up this pelvic floor muscle as her area of specialization. As I was talking to her, it was very heartening to see that she is one of the very few specialists in her province where people are working for not alone the female pelvic floor. It is even as important as how it is for a woman, it is for men too. You know, where this prostate gland plays with, you have to get your pelvic floor muscle tightened and strengthened. So it is quite common for even men to have this problem. In our country, it is picking up now. Pelvic floor muscle rehab is something which people really want to understand. And most importantly, it is easy to understand but very difficult to deliver it to the patient, where the patient have to understand the right contraction, how it is to be done. So where education plays a major role, and assessment by the therapist whether this muscle is getting activated or not is a big challenge. So that's how it is not alone people make money out of it, but the results are more rewarding. So as it is now happening at us, we thought why not we have her, and fortunately she is around here. She had come from US and she's here for a few more weeks or next week or like that. So we thought we should make use of it, and she immediately gave her consent, and that's how we are here. And in our institution also, with support from gynec department, we get women who visits regularly once in a while to get their pelvic floor muscle strength and understand. And now we have also started getting even men folk too. So this is one teaser, I should say, as sort of a trailer where she's going to give an understanding about what it is, how it works and how it functions, and the power we can understand how it goes. But it is just a teaser, as I said, long way to go. But I'm sure we'll be in touch with her for future, such programs where we could able to connect through air. We can have webinars, we can have some case studies, presentation, interaction, collaboration. It is just a one-point start. So it's a win-win situation both for our institution and an alumni, where we try and make ourselves visible to the society by having prominent alumni visiting our institution. So on behalf of Calcutta University and the faculty and the present students of KMPAP, we extend a very, very warm welcome to you, Ruchi. And it is our honor and pleasure to have you. And I hope this 1.5 hour sessions will be an eye-opener to many. And the sitting would-be physios will be getting inspired. Probably few may pick up this as their area of specialization in their post-graduation too, I guess. So thank you so much for accepting our invitation. Look forward to have more association with you. God bless. Thank you so much.
Thank you, sir. It is my pleasure to welcome Dr. Shweta Parekh, Academic In Charge, Professor, CAA Talk Coordinator, who will be introducing our esteemed speaker for the 12th CAA Talk.
Good afternoon, everyone. Principal sir, our faculty, and other dignitaries. It's my pleasure to introduce Dr. Ruchi Shah, a physical therapist specializing in orthopedic and pelvic floor rehabilitation. Dr. Shah earned her Bachelor of Physiotherapy from KMPAP in 2009 and her Doctor of Physical Therapy from Arcadia University, Pennsylvania. She is an American board certified orthopedic specialist, a certified Mulligan practitioner, and a pregnancy and postpartum corrective exercise specialist with a specialized training in pelvic floor dysfunction for both men and women. With over 13 years of experience and more than 7 in the pelvic health, she practices in OPD at the University of Pennsylvania. She is also teaching and assisting for the Doctor of Physical Therapy program at the University of Sciences and has been featured in Philadelphia Inquirer for her expertise. She is passionate about empowering and educating postpartum mothers. Hence, Dr. Shah launched Reform Dr. Ruchi, a virtual coaching platform providing accessible care and support to women worldwide. Her mission is to help women to regain strength, confidence and quality of life during especially postpartum journey. So please join me in welcoming our own alumni, Dr. Ruchi Shah.
I was feeling very nostalgic walking in that door.
nostalgic walking in this room, looking at those back chairs where we used to sit. And then Shweta gave this long introduction, and I'm like, oh man, I'm old now. But before I begin today's lecture, I want to take a moment to express my heartfelt gratitude. First and foremost, I want to sincerely thank Dr. Rajendra sir for giving me this incredible opportunity. It is truly an honor to be here. I also want to extend my deepest appreciation to Shweta Didi and Ashish Bhai for their efforts in organizing this and coordinating this session. And a very special thank you, it's long due, but a very special thank you to all my professors, my seniors, classmates and juniors, both present today and those who aren't. This institution gave me more than education. It instilled in me the values of discipline, integrity, patience, and the most important, resilience. These lessons have shaped me into the person and professional I am today. I will be forever grateful for the role each of you have played in my journey. Thank you. All right, before I get very emotional and somebody hands me a tissue, let's get to the lecture. So a lot of you know the basics of pelvic floor, the pelvic floor muscles. But I'm just going to run through quickly with the pelvic floor muscles just because each layer plays a specific role and has a specific function. So when you get a patient with a specific diagnosis, or if you find out something through assessment, you know which layer you are looking at. So this is layer 1. So for layer 1, when you have the patient in the lithotomy position, what you are seeing on the external is basically layer 1. All these reddish pink are muscles. And everything on the inside of the bone is the organs, okay? So when you look at this, these external pink on the top triangle and the external anal sphincter, these are part of layer 1. And its clinical relevance is in conditions of dyspareunia, fecal incontinence, childbirth, episiotomy is done through there, and pelvic pain. Layer 2. This is the layer that's different in men and women. Otherwise, men have pelvic floor, it's the same muscles for layer 1 and 3. Layer 2 is different, and its main function is voluntary urinary continence. So when we see stress and urge incontinence in women, we are dealing with different muscles just because of the difference in openings. And hypertonicity in cases of bladder pain syndrome and interstitial cystitis. So layer 2, when you assess internally, it's with the finger up, whereas layer 1 and layer 3 assessment happens with finger down. Just because also in the center lies the urethra. So when you test the muscles of layer 2, make sure to test it on 2 sides. Otherwise, the patient can have urinary tract infection with the manual testing of the urethra itself with the finger up. The third layer is the deepest layer, and that's what you see on the inside. All these beautiful pink is the layer 3 muscles. These muscles play a major role in everything that happens from top here. And these are the muscles that extend on the outside of the pelvis that eventually connects to the lower limb. So these muscles have clinical relevance in cases of prolapse, core instability, and back pain. If you have a back pain patient you've been treating for weeks and months, they get better for a little bit, and then they return back with the same complaints, then you definitely want to look into layer 3 pelvic floor muscles and treating those muscles for longer lasting results. And dyspareunia. Dyspareunia is basically pain with intercourse or insertion of tampon, or even with gynecological exam. We'll have a look into it a little bit later. 5 S's of pelvic floor function. First one is support. this supports the organs. The bladder, the uterus, and the rectum. Now imagine in hysterectomy, when this is taken out, this space remains the same, but there is a void in between. So what happens? There is a space in between, right? So everything happens, will be dysfunction. So either the pelvic floor muscles contract too much to maintain these organs in place, or the patient can even develop more constipation because there's more room now. Okay, so in cases of hysterectomy, that's what you're looking at, that there's more space on the inside of the bowl now. Sphincteric. Sphincteric is voluntary opening and closing of the sphincters of the urethra. That is a function of the pelvic floor. When the pelvic floor relaxes, then only the urine can be voided. And when it's not time to void urine, the pelvic floor stays in the contracted state, and it prevents unwanted leaks and ensures smooth flow of the urine and bowels. So think of the pelvic floor like a hammock for a swing, like a hammock that's tight on the two sides, and when 3 kids sit on it, that's how the pelvic floor handles all these 3 organs. Sexual. Pelvic floor muscles play a role in intimacy. It needs to relax during penetration. That's why the layer 1 is important. Otherwise, the posterior fourchette, that's where the patient experiences pain. So when you have a patient who says that I have pain with intimacy or inserting a tampon, the detailed question you ask is the pain upon penetration or is it upon deep thrusting? If the answer is penetration, then we are looking more at layer 1. If it's the deep thrusting, then we're looking more at layer 3. Now when you internally assess, when you have 1 knuckle in, that's when you are testing level layer 1. When the finger is up and 2 knuckles in, that's layer 2. And the finger down and 3 knuckles in, that's layer 3. Multiple studies have shown that pelvic floor physical therapy can really help in cases of dyspareunia. What all you can do is you can do manual release with a sweep technique, or you can do pressure and release. So on inhale, you let go your pressure from the muscles, and as the patient exhales, you put deep pressure on the areas that are painful. Many times, this wand is also given to the patient for home exercise program if the pain points are at much deeper level and they cannot reach. So this, and it's curved because of the shape of the pelvis. So if it's very tender and painful and the patient shows a lot of anxiety and is not able to talk it out more or able to discuss more, they are advised to use more of the round, easy shape. And then once the patient gets comfortable, then they start using the pointed shape. What happens is this, they are usually not very comfortable talking about it, and with over time, the pelvic floor muscles start getting tighter and tighter, and they start getting tensed. So because of this, then you start seeing other symptoms and other dysfunctions. And then when they come to you, you are actually seeing the end product and not able to determine that it started like this. So when a patient just even mentions that they have pain with insertion of a tampon or pain with intercourse, that's when we intervene and it really solves the issues at an earlier stage. It works as a sump pump. So just like all other systems, pelvic floor muscles work like a pump that helps recirculate fluids in our pelvis, contributing to our overall circulation and health. And the last one, stability, the most important one. Multiple studies through EMG have shown that pelvic floor muscle is an anticipatory muscle, which means that when your brain thinks you have to move the leg, the pelvic floor fires in anticipation. When you have a pelvic floor dysfunction, then that muscle firing does not happen in anticipation. So when you want to move the arm and have the ribcage breathing, the pelvic floor should be firing before that. When you want to walk and you lift the limb, pelvic floor should be acting before that. Because as you see, because as you see, it's a closed system. The diaphragm on the top, the multifida on the back, the sacrum, pelvic floor on the down, pubic symphysis on the lower front, and the transverse abdominis in the front. So it makes a closed system. What happens if you open the bottom? Or what happens if the bottom is loose? Right? The canister cannot maintain pressure. That's what happens. So if the pelvic floor does not fire in anticipation of moving the limb, then you see that little dip and little stroke because it has to fire with every single limb movement. Now, of course, when patient comes with pelvic floor dysfunction, you should test the pelvic floor muscle and test the strength and do all that things. But the 5 important, if you treat, just like any musculoskeletal condition, if you treat only one specific area, you won't see that much result. Until and unless you consider, when a patient comes with shoulder, you also consider the scapula, correct? Or you also consider the neck. Same thing with pelvic floor, because these are also muscles, it's just attached to the pelvis. You should consider testing these 5 muscles. And the first one, diaphragm. Why diaphragm? Because it makes the same closed canister system like this. It works in sync. On inhale, we all know the diaphragm goes down. And on exhale, it comes up. This is the diaphragm, this is the pelvic floor. It's all attached to the canister. So when on inhale, the diaphragm is going down, where should the pelvic floor be going? Down. It should move like this. And when an exhale, it's coming up, it should come up. It's a very subtle movement, so we don't notice it in daily routine. But if the pelvic floor is not going down with the diaphragm, then probably it's not coming up with the diaphragm. If it's staying stuck down on inhale and not coming up, what's happening? On exhale, the diaphragm is coming up, but the organs will keep on pushing down. The same thing with breathing. If you see a patient breathing with open mouth or breathing into their neck. So with breathing into the neck, the diaphragm is going up. So on exhale, the diaphragm is going to come down. On exhale, if it goes down, all these organs will be pushing down on the pelvic floor, increasing the chances of prolapse in their postpartum. You see a lot of neck breathing in postpartum women because of the stress and the hormones and everything going on. So what happens, the pressure constantly keeps on going down. Now, if you're going to lift something heavy on exhale, and it's a neck inhalation, the diaphragm is not going down smoothly, then on exhale, you are going to push the pelvic floor down and lift. What's going to happen? There's an increase in abdominal pressure, and you're pushing down all the organs. So you will see more symptoms of pelvic floor because you're not breathing correctly. If you all can give me 1 second, I want you all to put your right hand on your rib cage on the side. Alright, and the other hand on your belly. A little bit more on the side of the rib cage. Yeah, you'll all have to be uncomfortable with that wax up yourself. Close your eyes and on my verbal cues, go ahead and just inhale. Don't think about what I said, how you should breathe. Just notice how your right hand and your left hand moves. Let's give it 5 breaths. All right, where is the right hand moving? Up and out. Where is the left hand moving? That was on your belly. Out. It should be moving out, right? Now keeping the hands in the same position, I want you to relax and lean forward a little bit with your feet relaxed completely. Feet relaxed completely, close your eyes, leaning forward and just dropping your body weight on the chair. Drop your body weight on the chair. Close your eyes, no deep breaths, just regular breaths, please. And I want you to notice what happens in your bottom area, in your pelvic floor area. What happens on inhale? What happens on exhale? Or if you notice nothing. 5 regular breaths, please. Did we notice anything? What did we notice on inhale?
No, the lateral expansion increased, but this was creating more pressure inside.
Okay, and what happened on the bottom?
Nothing much.
While exhaling, pressure as in down pressure or up pressure? Okay. So that's what you have to experience first, and then only you'll be able to explain it to your patient. If you're not able to feel anything down, then we need to master that first before teaching our patients. How can we do that? Sitting on super soft surfaces, like you put 2 cushions, 3 cushions, where your glutes and your pelvic floor completely sinks in. And then you do mindful breathing. As I explained, if the diaphragm is going down, that means the belly is coming out, you should feel the pelvic floor on the cushion. It's a very subtle movement. And as it comes up and you feel the belly going up, you should feel the pelvic floor lifting up a little bit. That's the normal pattern. This is the first step you do with any pelvic floor dysfunction patients. So in order to know that, you should be able to feel that, then only you'll be able to explain it with confidence. Now, just like you all felt nothing, if you came to me and you said you felt nothing in spite of trying sitting on soft cushions and everything, nothing worked, right? You don't give up. What do? You break down breathing. You break down into side expansion and you break down into back expansion because the diaphragm is a dome, right? So you first treat the sides and the back breathing, and then you try that again. So with sides, if you lay down on a foam roller and open up one rib cage and and it increases the side expansions. And then usually the back is always tight, especially not just in postpartum population, but usually the back breathing, because of our stressful lives, has always gone down. So it won't be a bad idea. Open up the back rib cage and send some breath in. This would happen in a very quiet environment with no pressure if you want to see results. Why is, I've mentioned some pelvic floor dysfunctions that you would start with this, but it won't hurt in starting the patient just with this basics. And you gradually increase. Like if the patient is not getting understanding in the first session, you don't push them because you don't want them to feel like they are lagging too much behind or they cannot improve. Okay? Any questions on diaphragm, breathing, anything? Because anywhere you read our expert Google or anywhere, you read pelvic floor treatment, the first thing will come breathing. And we all think, oh, I know breathing, right? We all know breathing. But these specifications are very important. That when the patient is walking, the pelvic floor should naturally go down on inhale, come up on exhale, very subtle movement, but it should be a natural rhythm. Now, those of you who have straws, I beg you to put that in your mouth with the lips closed. So just do a little activity because, like I said, it's very important for you all to feel the muscles so that you're confident in explaining. So the straw goes with the lips. No space between the straw and the lips, okay? And if you can just sit with the feet on the side and relax. What you're going to do is inhale through the nose and exhale through the straw. Just that much, without thinking anything. No deep breaths, nothing. Inhale through the straw, inhale through the nose, exhale through the straw. One hand on the belly, one hand on the straw. Somebody is doing deep exhales. You should not hear the noise of exhale. Inhale through the nose, exhale through the straw. Now deep. Deep inhales, deep exhales like a pursed lip breathing. For the last two breaths, I want you to take a deep inhale, and as you exhale, I want you to think in your mind that you are going to gather your lower belly and pull it up as you exhale. One more. Deep inhale, and as you exhale, think about your lower belly band pulling up towards your chest. Notice any difference? Feel any muscles? That's your core. So that's how you start feeling your core. Sucking in, pushing your belly button down, tightening your tummy. Those verbal cues will not help your patient activate your core. When we talk about core, transversus abdominis, we are talking about a band of muscle that runs from one side of the pelvis to the other side of the pelvis. That pelvic floor function. So the patient should be able to do this breathing with all core exercises. With pelvic floor dysfunction, this pattern disrupts. This pattern becomes opposite. So that's where our role comes in teaching the patient the correct pattern so we can move further with more pelvic floor strengthening or lengthening, whichever is required. And these are the pelvic floor dysfunctions in which strengthening of the transversus abdominis muscles is very important. Now, the biggest question is, should core fire before floor or should core fire after pelvic floor? That's the biggest question. So, think like this. If the core fires first, where is the pressure going? Down. If this fires first, this contracts first, the pressure will go down. So the floor or the pelvic floor has to fire first and then the core. The third group of muscles will be adductors. Adductors have an anatomical connection and partial connections with the pelvic floor. So pubic symphysis pain is highly associated with disturbance in pelvic floor and adductor synergy. And so sometimes when they have pubic symphysis pain, we avoid strengthening the adductors because it's very painful, right? Studies have shown that ball squeezing the ball, that is adductor muscle isometrics, will fire maximum transversus abdominis. So just like you did the straw blowing, adductor isometrics fires even more transversus abdominis. Studies have shown it again and again. And also, like I said, pelvic floor needs to fire before transversus abdominis. So here we are able to link all these three. We are able to link adductors, transversus abdominis, pelvic floor, and you always squeeze on exhale, so breathing. All four muscles are connected. If you treat only one by itself, you will not see results. I did not have the patient lay down flat because of severe weakness in pelvic floor. Whenever I have a patient who is grade 3 or lower, I have them on 2 pillows so their pelvis is tilted back and the pelvic floor muscles, when they contract, gravity helps them. So that's how we start resting. So when you rest on 2 pillows or even 3 pillows, the glutes relax completely because glutes are the strongest muscles. If pelvic floor is weak, you ask them to do Kegels, the glutes are going to contract because they are stronger. When you put 2 or 3 pillows, tilt the pelvis back, the glutes relax. And then when you have the patient do adduction or pelvic floor strengthening, it is more like grade 2. So all of the concepts of strengthening, lengthening applies from musculoskeletal. It is just situated in a way that we have to look top and bottom. Next. All right, hip external rotators, both piriformis and obturator internus. Now those who do internal treatment and assessment, these are very, very important muscles to test and treat because these muscles are connected on the inside and the outside. These two are the muscles that go from inside to the outside. So those who do internal assessment, if you have your finger straight and then move it to 11 o'clock, that would be your obturator internus. And if you move it to 1 or 2 o'clock, that would be your obturator internus. When you have your finger in, turn it straight, 9 o'clock, 3 o'clock is your piriformis. These muscles can be released externally as well, but they are not as effective as internal. Same thing, these muscles can be treated with pressure, release strategies, sweeping techniques, or even using the wand. How do you palpate it externally? Is having more fingers. I just have 2 fingers, but you would usually cup under and do a resisted external rotation of the top leg. The muscle that you feel, that is obturator internus. And piriformis, we all know, it's between the 2 points, and you can even test it with this. So that's how you test it externally. If you find it tight, then please make sure you lengthen it first and then strengthen it. Okay, because if it's tight, then it will overcome all the activity of the pelvic floor muscles. We all know these stretches. So this is a seated 4 for piriformis stretch, and that is a mermaid stretch. We are stretching the left leg over there. Also, manual release externally as much as the patient can tolerate, just with our manual techniques, can be very, very beneficial. Psoas muscle. All right. I did not know this muscle existed till I started learning about pelvic floor. So psoas muscle is considered an emotional muscle. Neck, pelvic floor, and psoas muscle are considered emotional muscles. Why so? If a patient is under stress, or whenever we are under stress or have a busy routine, something going on in the mind, these three are the first muscles to tense up. That's why we see a lot of neck patients. Sometimes it's mostly the stress that gives neck pain, right? There is nothing wrong mechanically, or nothing shows up on the imaging. So psoas muscle, pelvic floor are called emotional muscles. And the manual release of psoas muscle is super deep. So it's just medial to the ASIs. Can it wait? I won't press that hard.
Sorry.
So you find an ASIS just medial to the ASIS, and you go deep, like it's super deep, sorry. You go super deep and you roll it side to side. That's where the psoas is. You can do a manual release if the patient can tolerate. A lot of times, especially in postpartum women, when we do psoas release, the tears come out, and I'm not kidding. Tears come out involuntary, and research has shown it's because it's connected, it's an emotional muscle. And the patient just keeps on apologizing that I'm not sure why I'm crying, but I'm okay. So that's how it's connected. So deep, and you roll it side to side. I'm not doing that. And side to side, okay? How you can give it to the patient for home exercise? A medium, not firm, but a medium firm ball. And that goes right on the medial to the ASIs. Once it's there, alright, bend the knee, and you roll it side to side. You tell the patient to roll it side to side, putting more pressure. Okay, and inhale and exhale. So the movement happens on exhale. That's when the pressure will happen. And on inhale, it will release. So the psoas muscle overactivity. Psoas muscle overactivity is related to prolonged sitting. Somebody who has a desk job and they're prolonged sitting, because the psoas connects the lumbar to the pelvis, it shortens. Shortening of the psoas happens. Its overactivity is in dyspareunia. Dyspareunia is the pain with intercourse that we discussed before. So when there is tightness and apprehension over here, that muscle goes into into shortening and overactivity, in constipation and pelvic pain symptoms. The weakness is linked in pelvic organ prolapse, stress urinary incontinence, and poor core lumbar stability. If the front is weak, every time you walk, bend, lift. The transversus, the rectus is not taking the weight, somebody has to. And that will be, the psoas muscle will show up. In chronic pelvic pain and SI joint pain, significant improvement have been seen when treating both psoas muscle and pelvic floor muscles. Alright, what is Kegels? We have heard this word a lot, right? So Kegels was initially named after Dr. Arnold Kegel, a gynecologist from University of Southern California, who recommended that strengthening of pelvic floor muscle will be beneficial. So just like strengthening of our biceps, strengthening of our hamstrings, it's just strengthening of pelvic floor muscles, it's just named as Kegel. What is the proper technique? It involves 3 components: squeeze, lift, and relax. The squeeze happens at layer 1, the lift happens from layer 3, and the relaxation is important. We all know if the biceps cannot completely relax, it cannot fire with the same amount the next time. The same situation. It's the length-tension relationship that changes, right? So when you even externally see a patient, you are not assessing the patient internally, you have the patient in the lithotomy position, you just ask them to do a Kegels or whatever they think Kegels is, and you just observe what they're doing. Then you ask them to do a squeeze, a lift, and a relaxation. If you don't notice this relaxation, then you just have that in back of your mind that probably this patient has a tight pelvic floor. Even without touching the patient, you can determine this. Then after a few other questions you can ask once the patient is more comfortable, and still if you don't see that relaxation, then your treatment will start with relaxation of muscles and then move to strengthening. Correct Kegels involve a quick release and a quick contraction as well. So they should, because it's fast twitch and slow twitch muscles. In pelvic floor muscles, they are fast twitch and slow twitch muscles. So they should be able to quickly contract, quickly relax, and able to hold for 10 seconds if they're optimally functioning. Okay. The biggest question is when to do Kegels and when not to do Kegels. If a patient has a tight pelvic floor and you do Kegels, even if you treat them for 8 weeks, 12 weeks, you will not see results because they already have a tight pelvic floor. It's like if there's a tight biceps, if there's a tight hamstring, and you keep on strengthening, overloading it, we will not see the results, right? So make sure you lengthen before you strengthen. How can you have the patient feel the Kegels muscle? Right? Because you'll be giving them home exercises and you need them to be compliant. For pelvic floor, how is pelvic floor therapy different than all other therapies like musculoskeletal therapy? I wouldn't say neuro because you need more compliance with that as well. In pelvic floor therapy, all us as clinicians can just give advice. It is the patient who has to do it in order to see the improvement. Okay, so we can guide them what to do, we can show them what to do, but if the patient is not compliant or if the patient does not perform it consistently and correctly, you will not see results. Okay, because you are not going to measure the angle of the knee, you are not going to measure the angle of the elbow. All you are going to determine whether a patient got better or not is by the symptoms, is by the improvement in symptoms, is by what they tell you. Correct? So, for Kegels, the same thing. You can have them sit on 2 to 3 soft cushions, lean forward, feet relaxed, And when they are in their own private setting, they can even have a hand right here on the pelvic floor. And you just ask them to slowly contract and slowly relax. Let them tell you what they feel. It is a very subtle movement. You have to create the environment and you have to make them comfortable. This is still a topic that's not very openly discussed. A lot of our relatives have it and we still don't know. Probably I still don't know, so I'm not able to even give them any advice. So you have to make them comfortable. They should feel like you are the person they can open up to. Lean forward, hand on the pelvic floor, and as they inhale, they should feel more pressure on the hand. As they exhale, they should feel the pelvic floor moving up. Okay. Now, if they tell you they feel a very strong contraction, then probably you might want to check the glutes. You might want to check the adductors at the origin because they might be compensating. If somebody has very weak pelvic floor, let's say 3 minus on assessment, then you might want to start them in this position, but with adduction, so a ball squeeze in between. When Kegels is a yes, when you have pelvic floor muscle weakness determined an assessment, after vaginal delivery, studies have shown that if a woman has a vaginal delivery and if it's not painful to do Kegels, it is safe to start doing Kegels soon after birth. Functional Kegel test. You tell them to voluntarily stop the urine. Those of you who don't do an internal assessment, you can ask this question to the patient. If you are on the commode and you are urinating, can you stop the urine flow midstream and then can you let it go? If they say no, then yes, you can give them Kegels and Trendelenburg test. So, with the Trendelenburg test, we know it's the gluteus medius, correct? That's the drop on the other side, correct? So that is a stabilizer. With Trendelenburg test, if the patient shows loss of balance, wobbliness, that is the pelvic floor weakness. Because pelvic floor, because it's on the bottom, it's supposed to fire before the leg lifts. It's supposed to maintain that balance and it's supposed to fire as an anticipatory muscle. When is Kegels a no for treatment? First, pain with intercourse, inserting tampon. Remember, you need to release it, you need to lengthen it. Dribbling of urine instead of a streamlined flow. If their jaw or masseter muscle is tight upon assessment. Jaw is connected to our pelvic floor muscles in 5 different ways, including embryological. External, internal assessment, they have difficulty to relax. They demonstrate stress or anxious nature. And there is tightness of obturator internus and piriformis upon external or internal assessment. Now somebody, when he asked, why do you have 2 pillows, right? That was because of the weakness. Now when you have somebody who is, again, coming with weakness, not able to understand, and is not sure if they are doing it correct, then you break it down. You break it down into anterior pelvic floor and posterior pelvic floor. Remember, you don't give up that this patient is not understanding, okay? You don't give up. You take a step back, you rewrite it, go back to the blackboard, start again. But you don't give up because this is very new. This is very new to them. This is very new to us also, and we are learning in the process. So if the patient is not able to do Kegels in all positions, you explain to them with the pillows, bridging position, everything, you break it down. Break it down into anterior pelvic floor and posterior pelvic floor. For anterior pelvic floor, it will be the leaning forward. That activates the anterior pelvic floor, and posterior would be leaning backward. They are the strong muscles. If somebody shows a grade 2, it won't be a bad idea to start with gluteus maximus strengthening. So that will be a global contraction. So you ask them to squeeze their butt cheeks. That is giving them a little bit of pelvic floor contraction with the overflow, but it is not a bad place to start with. Also with anterior pelvic floor, you can add resisted adduction. That will automatically fire the anterior pelvic floor muscles. And for posterior, you can add a resisted external rotation. Right. I'm going to discuss very common dysfunction, urge and stress incontinence. We have heard it a lot, right? What is it exactly? So urge and stress incontinence happens with different mechanisms. They are different dysfunctions. So it's very important to ask the correct questions in order to determine which type of incontinence they have, because the management will vary. They can also have mixed incontinence. They can say yes in some of these questions and some in those. So that is called as mixed incontinence. But for urge incontinence, it's the involuntary leakage of urine with sudden intense urge to urinate that they cannot delay. When does the first urge happen? In all of us, in every person with a normal functioning bladder and pelvic floor. First urge is mild awareness that happens when the bladder starts filling. Okay, we all are sitting here, we think, oh, we have this lecture for 1.5 hours, it's already half hour, it's 1 hour. I can go to the bathroom after this lecture is done. The second urge is about 2/3 full, and you think, if it lasts longer, I might just use the bathroom. But you're still able to control it. Okay? And the third one is near full capacity that you need to run right away. That's normal. Questions to ask. Do you have increased frequency? Do you go to the bathroom often? Often meaning they go once, twice, or thrice in an hour, 2 hours. Once in 2 hours is normal. If they go more than that, that's increased frequency. Increased urgency is they have to go to the bathroom with the thought of going to the bathroom. With the thought of tap water running, when they turn the shower on, they have to pee. Those are urgency. They dribble or leak till they make it to the bathroom, and they are fine getting to the house. But as soon as they put the key in the door, they have to run to the bathroom. That is a part of urge incontinence. The best way to find out is have them fill out a bladder diary on 3 separate days, where they'll write down everything that they ate, drank, how many times they went to the bathroom, how many seconds did they pee, which is very important, and how many times did they have the leak. So sometimes from that, you can figure out if there are more bladder irritants in their intake, which is causing them to go to the bathroom so often. For urge incontinence, the best treatment is a bladder retraining program. It's just a fancy name for potty training the kids. Just like we potty train the kids, potty training adults is called a bladder retraining program, where we give specific commands. We teach them, instruct them to do specific commands, specific things at specific intervals in order to see the results. Just like when you're potty training a kid out of diaper, you put them on the commode at a certain time, whether they tell you or not to go to the bathroom, right? The first one is heel raises. Now, there are many over here. Does not mean you have to give them all to the patient on the first go. Otherwise, the compliance level will go down very much. Okay, so you start slow. Based on your assessment, you determine which is the most important thing that I can give the patient that they will comply with, and then build it up. Okay, they need to build trust in you. The first one is heel raises upon urge. So, how does this go? Every time the patient has the urge to go to the bathroom, and it can be quite annoying. Sometimes these patients go to the bathroom 20 times a day, which is a lot. And they go to the bathroom 3 to 4 times a night. So with heel raises, what happens every time they have the urge to go to the bathroom, they're going to stop wherever they are, do 10 heel raises, and then start walking to the bathroom. Now, is this a mental thing? Absolutely not. Our brain has a representation of every single body part. So when you increase the activity of one, the one next to it suppresses just a little bit so that the patient gets time to make it to the bathroom. The representation of ankle and toes is right next to the bladder or the genitalia. So when you increase the activity of that, the patient gets the time to make it to the bathroom without leaking. And this, when the patient is in the training phase, they have to do it every single time they have the urge, which means they have to do it at night as well, which is very annoying. But the brain recognizes the movement, right? The brain does not recognize the muscle, it recognizes the movement. So if it's consistent, then the brain understands that when I have that urge, I need to give it time to make it to the bathroom. Usually, multiple studies have actually shown that for pelvic floor therapy, in order to see results, you have to give 12 weeks because we are making changes in the actual motor units in the brain. Okay, so it takes 12 weeks. So on the very first visit, your patient is going to ask you, how long is it going to take for my symptoms to go away? How long is it going to take? How long I have to come, right? And all patients vary, but you don't want to give them that answer, right? That all patients vary. What you tell them is, studies have shown that it can take up to 12 weeks to see changes in your symptoms. However, it's not necessary I will see you for 12 weeks, but you need to be patient with me and I need to be patient with you to see these changes. And for pelvic floor therapy, all I can do is I can give you tips, I can show you movements, but you are the one who have to do it. Based on your feedback, we will decide which direction to move. Okay, so on the very first visit, you make it clear to the patient that this is going to be a little bit of a process, and you won't see that increase in range of motion, and you won't see those visible, actionable measures. Quick flicks. Whenever they have the urge, they can just do 10 quick flicks if they have a strong pelvic floor. 10 quick flicks. Contract, relax, contract, relax, contract, relax. And then whenever it's an appropriate time or an appropriate situation to go to the bathroom, they can go to the bathroom. Because with that quick fix also, the urge suppresses a little bit. Double voiding technique. So most of the times in urge incontinence, the patient is going so often to the bathroom because they are not able to completely empty the bladder in the first time. So what happens? There's a residual urine, right? When the bladder starts filling next time, and it's not to the full capacity, way before that, they'll start feeling, I need to go to the bathroom. So what we do is with the double voiding technique, once the patient is done urinating, the first time on the commode, they stand up, and if they are usually at home, what I would have them do is do high marches that presses on the lower abdomen. So 10 high marches. Then they take both hands, put it on the lower belly, press it a little bit, sit down on the commode and just relax. If that residual urine comes out, good. If not, they are done. You don't stress on pushing and straining. Okay? But this also has to be done every single time they go to the bathroom. Remember, consistency is the key. So you have to keep on enforcing that. The third one, and a very important one that patients don't notice, is constipation. When the rectum is full or the rectum is not completely empty, what happens? It will push on the other organs. It will push on the bladder. So just with a little bit of urine or just half-filled urine, that constipation will be pushing on the bladder, giving that urge to go to the bathroom. Right, so you ask their bowel movement patterns, but you, regardless of that, you tell them to put a stool under the feet for bowel movement. It should not be very high. The knee should just be slightly higher than your hip, creating that posterior tilt of the pelvis, bringing the rectum right to gravity. Okay? So regardless whether the patient reports constipation or not, this trick works like magic. Reviewing of the bladder diary for bladder irritants, voiding intervals, and leaks. So if you notice on the bladder diary that the patient is going a lot, 2-3 times in 2 hours, you put them on timed voiding session. If they are going every 45 minutes, you just ask them for, let's say, if we can do it for 1 hour. Okay, and all of this happens without reducing the amount of water intake. Most of the times you'll have to increase the water intake regardless of this treatment, and I'll explain why. But you should really look for bladder irritants in their bladder diary, okay? Lemon water, all of those are considered as bladder irritants and then sipping coffee or tea all throughout the day. They can have a full cup of coffee or tea, but if it goes in one time, they will urinate after an hour instead of 2 hours. But if they keep on sipping throughout the day or have multiple small amounts, so every time it goes, it is poking the bladder and increasing the sensitivity and making them to go to the bathroom. For bladder retraining program, you have to also consider strengthening and lengthening of the pelvic floor muscles based on the assessment and adequate hydration. So what are the norms? First and foremost, bladder capacity does not decrease with age. Okay, the habits change with age, but the bladder capacity itself does not decrease with age. The capacity to hold the urine longer changes because of the surrounding factors. 5 to 8 times a day in 24 hours is the norm. 0 to 1 time at night. 0 is ideal, but if they have to go, it's fine. Also, the patients who complain about multiple times going to the bathroom at night, you might want to ask them, do you go to the bathroom because you are awake, or do you wake up because you have to go to the bathroom? Because if they go to the bathroom because they are awake, then you are looking into other issues, hormonal issues or stress issues or something else. Volume voided. So when you do the bladder diary, you are going to ask them to count it in seconds. 1, 1,000, 2, 2,000, 3, 3,000, 4, 4,000. So usually 7 to 8,000 is normal. The first void in the morning would be longer because of the overnight filling. But if it's 1 or 2 or 3,000, then they went to the bathroom too fast before the full filling of the bladder. When they are on a bladder retraining program, you would usually advise them to reduce or stop the water intake after 7 p.m. They can take only a full glass if they have to take a medicine. Otherwise, they should stop after 7 p.m. large amounts, just sips of water. If they have to do it, it should be 2 hours before going to bed. You take the big water intake, raise your feet, elevate it, do ankle pumps 15-20 times, and then because the kidneys take 2 hours to dump into the bladder. Okay, so if you do those, you'll have 2 hours. You can urinate before you go to bed, and that would be all for the night. Hydration, a very important thing. How much do you drink water? 2 liters, 3 liters, 4 liters? No guesses. Everybody's water intake is different. It depends on the body weight, because whatever water you drink is going to these cells of the body. Okay, they are hydrating all these tiny cells of our body. So it should be half of your body weight in ounces. Pure water. No cucumber, mint, lemon tea, iced tea, lemon water, coconut water. All those don't count towards this calculation. Let's say someone weighs 50 kgs, that is 110 pounds. So that would be 55 ounces, 1.6 liters. This amount increases a little bit during summers. Okay, otherwise, in general, you should be having at least this much of pure water, nothing added to it. And studies have shown that no significant increase in incontinence was noted when patients with incontinence increased their water intake. They are not directly connected. It's more about habits. Even when we were kids, as soon as we headed out of the house, our moms would say, just go to the bathroom, just in case we are headed out. So those patterns build up, and those patterns show symptoms. Stress incontinence. So the mechanism for this incontinence is a little bit different. Most of the times what we see in our clinics is usually urgent incontinence, but you definitely want to rule this out. So stress incontinence is involuntary leakage with activities that increase the intra-abdominal pressure. Just like we noticed, we decrease the intra-abdominal pressure on exhale, increase it on inhale. So it increases on coughing, laughing, sneezing, bending, running, jumping, all those things, right? So when a patient has complaint of leakage, when they do these activities, then it's a part of stress incontinence. what happens is, whenever normal individuals who have no symptoms, whenever they are going to cough, their superficial pelvic floor muscles will contract voluntarily, and then their deep pelvic floor muscles. So it will keep the bladder and all other organs supported and not opening the sphincter. Whereas in incontinent women, they contract the deep muscles first and then the superficial. So they are not able to control the leakage. How can you determine what's happening? If you have an external observation of the patient, you ask them to cough. When they are coughing, all of this is bulging down towards you. If you're standing right here, all of this while coughing is bulging down towards you. That means the leakage is happening in that way. Okay, so how do you treat it? So this is again just like we were taught as kids. Before you are going to cough, cover your mouth and then cough, right? We were reminded multiple times and we practiced it multiple times. So now as adults, we don't even think. Before we are going to cough, we cover our mouth, right? Because the brain has learned the pattern. So as a part of exercise, you tell them you are going to voluntarily, intentionally do the coughing exercise. You're going to squeeze your pelvic floor and cough. Relax. Squeeze your pelvic floor, cough, relax. You're going to do it multiple times a day in batches. As they keep on doing this, the brain learns the pattern, and then eventually the pelvic floor will contract before they're going to cough, sneeze, laugh. Diaphragmatic exercise is super duper important in stress incontinence because the down and the up mechanism is not happening. That's when exhale is happening, the pressure is coming down. So treating them with side breathing, back breathing, and breaking it down all to the basics is very important in stress incontinence. And trunk rotation. If you see postpartum women, this is the most limited movement. I'm not talking about the waist, just the trunk. So if that does not have enough movement, there is not enough air going down here. If there is not enough air going down here, it's going more down. And it's pressing on these organs. If a person has complaint of leaking only when they are jumping, so what you start with, you ask them to do quick, short, forceful exhales and jumping as they jump. Okay, so you give them treatment, whatever symptoms they have. Okay, you just back it up a little bit and then just give that as a form of exercise. Adductor and glute strengthening will help a lot in stress incontinence. And the hip hinge squats, we'll see that in a minute. Actually, this exercise I can show them somebody. One of the most important things we were taught in this school was you work with what you have. Again, I'm going to add a component of adductors. So I'm going to have a ball, put it here, and it stays there. Arm out. We are going to do the mid-trunk rotation to open that space up to improve breathing. So what she's going to do is start over here without moving anything from down below. You're going to rotate back. Bend your elbow, so you put puts less stress on your shoulders. Good. This is a little bit too much because if I let go, you are falling back, right? So you come forward and then you go back. Back. Good. And back. A little bit even less of that. So we should not see this movement. Okay. And that's it. And back. Okay. So while she's doing this, you can also give commands to do the adduction. So that will help with the pelvic floor contraction. But we don't want the patient to think of a lot of things. So some things we make passive and the other things we keep it active. And this can be given as a part of home exercise. Also, once the patient learns a good technique, you can add weight to the dumbbells. So that will help with strength.
Are we going to incorporate any breathing with this?
Not with this one, because then it becomes very confusing for a patient. So in the initial stages, usually breathing is given only as an independent exercise so that they can master that. But if we want to incorporate breathing, then I would put a little bit of towel here. So with side line, there would be more breathing on this side. And when we go to the other side, it would be more on the other side. So, next one, please. No, this is the slide. Yes. So some of these are my favorite exercises that I usually start the patients on third or fourth visit. This is again a mid-trunk rotation, but with resistance. So what we saw was just mid-trunk rotation. As soon as you start the pelvis and the hip, you start losing balance because you have a lot of resistance. So with this, if you train this will open up, sending less pressure down, and it's very helpful in patients, especially with stress and confidence. We have all seen this exercise, right? Bulldog or Superman or arm and leg extensions and all sorts of things. If you want to strengthen the core, then you have to move very slow in this exercise. All you do is you stand in front of the patient, knees exactly wrist width apart, shoulder width apart, perfect. Good. Without any specific commands, first you just tell the patient, you take your right leg back. You go ahead and extend your right leg back and bring it back. Extend your left leg back and bring it back. Okay. What you're going to see from here is how much she shifted the hips. The more she shifts the hip, the less control she has on that lower core band. Okay. Now I want you to go ahead and exhale. Okay. Good job. Right there. So hold everything neutral. Okay. Your arms should not move. Your shoulders should not move. Think of if you have a cup over here, it should not fall. Okay. Now I have my hand on your core. Go ahead and give me a core contraction, whatever you think that is. Very good. And relax. Okay. Let's have a core contraction in a way that nobody else notices here. Let's have no movement over here. Very good. And relax. I want you to add that with an exhale. Wonderful. One more. So I'm feeling it right inside the ASIs. You find the ASIs and you just drop your hands in that hollow. That's where your T is attached. and hold. I want you to go ahead and extend your right leg. And down. Okay. So in this case, because she's still moving, what I would do is I would tell her to slide her leg and not lift it up. Give me a core contraction. Slide your right leg back. Very good. And bring it back. Okay. Go ahead and slide it one more time. Very good. And a little bit more. Give me a core contraction. And not moving the pelvis, okay? And relax. Good. Give me a core contraction. 50% of what you gave me. Relax. Give me a core contraction. Good. Lift your left arm up. And down. Give me a core contraction. Lift your right arm up. And down. So I would move it with the arms first for her, and then slide the legs. And then once she gets that control, that's when a full bird dog will be initiated. That's when the core will actually get strengthened. Good? Any questions on this? This exercise can help with a variety of musculoskeletal and pelvic floor dysfunctions if they are done correctly.
The floor is open for questions. If anybody has any questions, anything, you can feel free to ask it. Anybody has any questions? Please raise your hands and you can from there you can
Is
ask.
this course in abroad? Is there any course we can pursue it in India, which is like good and it can teach us the knowledge? As in our curriculum, it's not specific to study pelvic floor rehabilitation. We studied in CT